Now, special inferior wall MIs, quickly I'm going to run through this. A true posterior MI, ST elevation in 2-3 AVF, right coronary artery, along with inferior leads. Tall R wave with ST depression in V1, V2. Now, what that means, I'll tell you in a second. A posterior descending artery from either RCA or left circumflex. Now, that posterior descending artery becomes very important to us, does it not? In anatomy, if you remember, you refer to what's known as right dominant and left dominant. Majority of your patients will be right dominant, right? That's because a posterior descending artery might be coming off of that. So what you need to take out of this for you clinically, and any question that you might get from anatomy, is what is it that dictates or determines whether you're right dominant or left dominant? If it's right dominant, it is the posterior descending artery. If it arises from the RCA, obviously your patient is right dominant. If it arises from your left circumflex, your patient is left dominant. Majority of your patients will be right dominant. Keep that in mind. It'll help you. ST depression in early precordial leads may actually not be reciprocal changes. Now, this is a bit much in terms of information, but this is a posterior MI. At least keep in mind that we have 2-3 AVF with an ST elevation, and keep in mind where we just explained posterior descending artery and its determination of dominance. Let's take a look at right ventricular infarction. How does this even occur, right ventricular infarction? Once again, we have the RCA, and this would also be leads 2-3 in AVF. Now, because we are in the right ventricle, I want you to think of V4, or not so much V5, V6, because that'll take you to lateral. Profound hypertension with nitroglycerin, beta blockers, and administer fluids in your patient. Right ventricular infarction. You're worried about your patient not having proper output. And hypertension, meaning to say that what are you doing? You're causing preload to be decreased, resulting in profound hypertension because the right ventricle isn't working properly. Look for those type of clues in which you know your patient is suffering from RVI. Now, ultimately, it comes down to cardiac enzymes. On this table, the most important cardiac enzyme that I have referred to over and over again is troponin I. Now, there's another enzyme that we will quickly discuss, and that would be CKMB. And this is the table format in which we're showing you the cardiac enzyme. But I'd like for you to focus on this graph, and I'll walk you through this so that you clearly see why it is that troponin I is the gold standard of your cardiac enzymes. Now, back up for a second, please. Would you find any cardiac enzyme to be elevated in angina? No, you do not. I don't care if it's stable or unstable. You're not going to find elevated cardiac enzyme. Keep that in mind. It is that black and white. Has to be. Now, if you go into myocardial infarction, sure. Now, the one that you're paying attention to, you see the long dashed green line, the troponins. Look how quickly the x-axis here represents the days and the time. The y-axis represents the amount or concentration. So, the dashed long lines of troponin elevates immediately at 24 hours, and look how long it lasts. A week. So very difficult for you to miss an MI in a patient if you're measuring troponin. Hopefully it's not beyond a week. With that, I don't even know what to say. But anyhow, the other important component is the CKMB. It used to be the gold standard. Now, pretty much the same reason, because it's elevated within 24 hours. But the reason that troponin trumps it, what kind of troponin, by the way? I. The reason that it trumps it is because CKMB disappears. How long? 3 days. It's gone. Now, if you did find a CKMB to be elevated beyond 3 days, then what do you know about your patient? Had a re-infarct, huh? Had a re-infarct. Now, there is something called an LDH isozyme flip, in which the normal LDH type 2 is then replaced by LDH type 1. Just know that it exists. But your gold standard will be troponin. Understand the significance of your CKMB rising above or beyond day 3.